Thank you for that, David, and may I give very friendly greetings to every one of you. I'm hugely pleased by your interest in children. I can't thank you enough for that. So, of course, interest in a child implies interest in an entire family. So you'll hear comments this afternoon based on child and based on family. And what I hope to do is to offer you a brief glimpse of the work that we did as a committee and then some selected reflections on what's changed as a result of the IOM report on children dying in America. And I am excited to share with you that there are definite changes in the positive direction that I can link specifically to this IOM report. As I share these reflections with you, I want so very much to give credit to a number of IOM staffers, most particularly Dr. Marilyn Field, Dr. Adrian Stith-Butler, and others who together put these ideas on paper. I'd like very much to introduce you to one of the fathers who was an expert witness and provided testimony to us. We had almost a dozen parents speak to us about their experience of losing one or more children. And what I emphasize to you is, of course, their sensitivity in their testimony, but also how very much they disagreed with each other. And therein lies the message of how our care must be individualized to match each family and how each family changes in front of us as they experience the dying of their child. But if I may please quote this father for you, "We are in need of medicine with a heart. The endless physical, emotional, and financial burdens that a family carries when their child dies makes you totally incapable as a parent of dealing with incompetence and insensitivity." We in pediatrics often have, as I have today following Chris, the opportunity of watching adults and our adult providers. You take care of so many more dying individuals in America, many more times the number of children who die. In America, between 54 and 62,000 children will die every year, the great majority of those being younger than a year of age. But always, we learn from our adults. And so indeed, the pediatric report followed two IOM reports that were based very much on the adult world. I also want to share with you that our report was sponsored by multiple organizations, most especially and first the National Institute of Nursing Research, but followed by 4 other institutes on campus, 3 foundations, and HRSA. I'd like to pay homage to the members of our committee, most particularly our chair, Dr. Dick Behrman, who artfully held us to a high standard of not offering opinions, but offering data-based evidence and interpretations. You'll notice on our committee that we were well represented in terms of medicine, nursing, psychology, social work, chaplaincy, the law, and economics. And you'll see the touch of that expertise on future recommendations. Much like any IOM committee, we experienced public hearings, we had expert testimony, we commissioned or we wrote chapters in the book, we had then public review of our book, and then we published the book. I'd like to say to you, we had a very definite charge to our committee, and it is this, that we would examine the causes and the settings of death in childhood. We would investigate both palliative and end-of-life, as well as bereavement care in America. We would look at how strong is the knowledge base to provide palliative end-of-life and bereavement care. And we would then be charged with proposing research and action items for an agenda for America. We did have key themes, much like Chris reported for the adult report. I'm only going to briefly touch on these, and that is that first of all, we assumed that a child's death has lasting repercussions for all those affected by the death, most essentially, of course, the family, but the community and also the healthcare providers. We also assume that although there is good care available, not every child received that. And that in particularly, good care was sometimes prevented from being given because we had organizational barriers and we had financial barriers. And we also had inadequate knowledge. When we tried to find knowledge about good end-of-life care and symptom management, it was limited, even skimpy. Within the first hour of meeting as a committee, I raised the issue about definition. Were we as a committee going to distinguish between palliative care and end-of-life care? Not because we wanted an artificial separation, but because we wanted to make the point that they are related, and therefore healthcare policy should be related as well. So I offer you here a slide that touches upon our key characteristics for palliative care and distinguish that from our key characteristics of end-of-life care. They were very much, and purposely so, integrated in our thinking and in our written documents. We divided our recommendations into 4 major categories, care delivery being the first. We recommended that there be practice guidelines developed across our nation for pediatric end-of-life care, and that there be both nationwide and institutional protocols to guide this care. As part of those guidelines, we recommended that families and children be given all the information that we had related to diagnosis and prognosis and what to expect as a life of a child would be ending. We also recommended that in those guidelines there be instructions on how clinicians could help families to set goals for end-of-life care. And that we have guidelines that would address how could we as clinicians give expert symptom care, particularly addressing pain management, and guidelines for how we as clinicians could include families and children in end-of-life decision-making. We wanted it to be made very clear in those guidelines that a group, a body within an institution be charged with developing end-of-life care guidelines and be held responsible for championing those guidelines. We also wanted to have at the state and regional level information systems that could be made readily available to clinicians and families. No one would be alone in providing end-of-life care. So now I'd like to cite for you admittedly selective examples of what's different since the report was released to now. And the confidence I have in linking this to the IOM report is that these changes specifically cited the 2002 IOM report of dying in America as a child. So first of all, we do have national standards. Now these do not come from a federal group. They come from organizations such as the NHPCO. However, these are readily available for clinicians who are interested in providing compassionate, competent end-of-life care for families and for children. We also have this available through medical and nursing specialties that have often aligned together to provide this kind of pediatric end-of-life resource. And I offer you as an example the Children's Oncology Group and the National Association of Hematology and Oncology Nursing. We also have regional and state examples, some of which are interestingly funded, so we know that we have still some challenges related to funding of these initiatives. First of all, we have an example in the state of Vermont for a rural palliative care network to make readily available clinical experts in pediatric palliative care to any clinician within the state. I'd like to point out to you that this impressive initiative is funded by a private donor. We also have a statewide initiative that is funded by the level of state government, and this is in Massachusetts. And this was an effort to provide all needed palliative care and end-of-life care for children 19 years of age and younger, a model for the nation. Now, Maryland has created an advisory panel and has made recommendations for funding. These are still under consideration and have been under consideration at the state level for 2 years. So these exemplars show you what is in place and what is still in limbo. Also related to care delivery, we recommended that there be protocols and procedures to go after the care needs of bereavement, not just for family, but also for clinicians. Clinicians who specialize in palliative care and those who don't, but are affected by having to provide that kind of care, such as emergency providers or generalists who are not well schooled in this kind of care. Now, this is an area where we are still needing progress, but we do have examples that I would like to share with you. One is that in the last 2 years, we have implemented nationwide a pediatric curriculum called EPIC. Now, this takes off after the adult version of this curriculum. It's just been offered in selective sites. We offer it again in April in Miami. The attendance has been impressive. Generalists are primarily attending this curriculum. It's about a 2-day curriculum. In looking at conferences that have been provided by different disciplines and organizations in pediatrics, it is rare not to find a workshop or a panel presentation on palliative and end-of-life care. This is much more in demand now. It's not the exception. When we issued the report, about 25% of children's hospitals had a pediatric palliative care team. We are now almost at 60%, so a dramatic improvement, but we should be asking ourselves, why not 100%? I also want to share with you that there are now tools that have been published to solicit the pediatric voice in end-of-life decision-making, and they differ developmentally. So in 2012, we have newly available to us Voicing My Choices. This is about advanced care planning, and it is for adolescents and young adults. But in 2006, the child version of My Wishes became available in a validated form and is being used in some practices. This is not universal. The second area that we made recommendations for is financing. Now, I want to share with you that this was an area of particular concern for us and one that we were doubtful that we could have much impact on, but we knew it was one of the biggest need areas. So we wanted to have then both public and private funding available for palliative and end-of-life care, and that would cover all children and would expand the kind of coverage that was available. Previously, it was a very selective availability, and it was defined what kind of end-of-life care could be, and we actually available, and we challenged the idea of the 6-month rule that was guiding much of the government-based support. Again, I'd like to hearken back to that example in Massachusetts, which is for 19 and under, and that does not have the 6-month rule available to it. I don't know the cost that the state has accrued because of this benefit, but it is well worth looking into. In many ways, we have what are demonstration projects across the nation in seven different states and the District of Columbia. It is well worth looking at the financial impact of those benefits that are available, admittedly, in a limited manner. We also recommended again that we have extended coverage for palliative care and that we broaden the number of children, including those who are amongst the most costly, that previously had not been given coverage. And you'll see again, we're going after bereavement in our recommendations. And I would share with you that this is the area that remains a vulnerability in pediatric health care. We have not accomplished the goals in bereavement that we recommended. We do, however, with funding at this level, now have examples at the federal level, and I'm really pleased to share with you these two examples where the government has stepped in and broadened its benefit for children, much as we recommended. Now, what we haven't been able to fully eliminate is, however, the 6-month life limitation requirement. I'm going to move quickly because I recognize the time considerations. My apologies for now moving faster. We do have other recommendations in terms of cost and coding so that we can look more systematically across the nation at the impact of costs. I do want to share with you that once again at the level of the federal government and state government, we do have examples of coding becoming standardized and wider benefits becoming available up to the age of 21. The third category of our recommendations was education, and this is an area again where we have definite positive outcomes. We recommended that there be educational experiences at all levels of providers, and for medicine that went from medical student, residents, and fellows, and board certification, and similarly for nursing. We asked that there be specific curricula that would be implemented that would make generalists more comfortable with pediatric palliative care and specialists even more advanced in what they were offering. I've mentioned to you already that from the specialty level, we have offered this particular curriculum, the Pediatric EPIT. And now I'd like to really praise what medicine has done, and much as Chris mentioned, beginning in 2006, the pediatric specialty now at the board level for hospice and palliative care, and there are now several hundred physicians who are specializing and board certified in pediatric palliative care. We are excited about this advance. I'm also very excited to pay homage to what has happened in nursing. We now have a national certification for hospice and palliative care, and several hundred nurses have become certified in a relatively short period of time. Please, if I may also pay homage to the ACGME, this is now a mandate requiring that some level of pediatric training be in residency programs. Now notice the broad definition, please, that a program content be available to impact the impact of chronic diseases, terminal conditions, and death on patients and their families. Now, it's very loose language, and how it's being approached is somewhat loose as well, but the language is now present and could be made stronger. Our fourth and final category of recommendations was research. And again, we have very positive examples, though limited, and I hope you will join me in hoping for more in this area. We recommended that particularly NIH and other federal agencies collaborate to improve the collection of basic demographic, descriptive epidemiologic data about a child's dying. We were lacking that when we attempted to do the report. We also recommended that the funders, including again NIH, develop centers of excellence and develop research priorities. We further went on to ask for developmentally appropriate instruments and measures to help a child's voice be heard at end of life and the family preferences to be documented. And now I'd like to call your attention to some very positive outcomes that we can say are directly linked to the IOM report. First of all, the National Institute of Nursing Research, since the publication of that report, has in fact convened 2 priority-setting meetings. They were think tank meetings, and they were specific to pediatric palliative care. Multiple recommendations were made from both of those particular meetings. In addition, NINR has had 2 priority conferences and has featured end of life, including pediatrics. May I also call your attention to an action that was taken by NINR, which was to create an office in 2009. This is an office that is led by Dr. Jerry Miller to address research needs, but also education and clinical priorities. So clearly, NINR has stepped forward as the anointed leader on NIH campus for palliative and end-of-life care, including pediatrics. May I also call your attention to an RFA and a PA that was issued by NINR, in which had multiple responses, and we're hoping for more from NINR and other institutes with designated funding for palliative and end-of-life care, including with children and families. So please, if I may, recapitulate for you, and that is that we do believe that we are in a better position to provide more effective, consistent, compassionate care for children and families. We do believe that there are improvements with palliative and end-of-life care. I do not believe that we have begun to address what is needed with bereavement care, and it appears to us that that is because of finances. We definitely need more research so that we can continue to address symptoms, decision-making, the level at which children and family voices can be incorporated into our care processes. So as I began, please may I conclude with a parent quote, also a parent who provided testimony, and with her permission, speaking about a provider connecting with her at the time of her child's death. Her words concerning his death and the choices I made continue to comfort me. She said, "You did the right thing." Such simple words, but what comfort they give me 4 years later. Thank you so very much for your kind attention. Please, if I may, respond to any questions. Thank you.